The inability for every single agency to just do the basics of their job properly has led to this catastrophe.
We go on the side of the patient far too much, and we don't take the steps that we could to contain them.
I fundamentally think that the mental health system is quite broken.
There shouldn't be a budget put on public safety.
I can't believe the number of calls we get of people who are saying we need to be somewhere safe. We're not safe with ourselves.
If you don't hold people to account, we will not get system change. This just cannot happen again. This should be the last inquiry.
Grace O'Malley Kumar, Barnaby Webber, Ian Coates. Their names instantly recognisable for the worst of reasons. Stabbed to death in Nottingham in 2023 by Valdo Callacane, a paranoid schizophrenic. He tried to kill 3 others that day too. Callacane is currently serving an indefinite hospital order after pleading guilty to 3 counts of manslaughter on the grounds of diminished responsibility and 3 counts of attempted murder. It is one of those attacks which genuinely shocked the country. The brutality, 2 young students, a loving grandfather. But as the public inquiry into what happened comes to an end, a report not due till next year, the shock now is at the sheer scale of failures across institutions charged with our safety and our sense of justice. The NHS, the police, the Crown Prosecution Service, the university. And the language of those failures so familiar. Missed opportunities, lessons to be learned. We wish we had done more. Such tragedies are unique, of course, to the victims, their loved ones. But the failings, well, they are far from unique. The 1993 report into the killing of Jonathan Zito by paranoid schizophrenic Christopher Clunis sounds staggeringly familiar. A catalogue of failure and missed opportunity. Failure to assess risk, to communicate. Clunis repeatedly disengaged from treatment, missed appointments and stopped taking medication. In 2005, Nicola Edgington killed her mother, was detained, then released. She repeatedly warned professionals she was becoming dangerous and then went on to kill a stranger. The investigation found a failure to assess risk and to respond to warnings. So today, on a special episode of the Fourcast, we ask, are we failing to learn the lessons when the price of those mistakes is so high? None higher than for the families left bereaved and broken. Well, joining me here today is Emma Webber, Barnaby's mother, James Coates, son of Ian, and Dr. Sanjoy Kumar, Grace's father. We're also joined by mental health charity SANE's chief executive, Marjorie Wallace, Professor of Mental Health and Diversity at the Institute of Psychiatry at King's College London, Dinesh Bhugra, and former Care Minister, Norman Lamb. Thanks to all of you for coming in today. We will be going into some of the issues in quite a lot of detail, but I wonder at the end of the inquiry if you as the families could give me a sense of what your overarching feelings and thoughts are right now. Starting with you, Emma.
Yeah, hi. Well, we're sort of at the end, but not at the end, because we've concluded the oral part of the evidence, but it feels in some ways like it's just beginning now. The work is just starting. It's been exhausting. It's been brutal. It's been harrowing. It's been so frustrating and heartbreaking. But actually, I think we feel a sense of validation that what we thought was so wrong really was that wrong, and we've got some of those answers that we've been calling for nearly 3 years now.
I mean, James, in a sense, Emma says, it's a lot of what you as the families already knew. Were you left surprised or shocked at any point by what you've heard?
Both. I feel going into the inquiry, I assumed I knew everything, all the mistakes, the missed opportunities, the warrants, the WhatsApp groups. I assumed I'd seen it all, but my eyes have been blown wide open with the amount of evidence that's been laid out in front of us. And yeah, shocking, disgusting. I think every emotion we've all been through. So.
Sanjoy.
I think being a clinician, I could see a level of detail that was kind of more microscopic in a way. It's been a lot of hard work. Life has kind of stood still for me since the 13th of June 2023. written a vast amount of questions, asking about why things went wrong, a lot of explanations. But mainly it's my big list of questions, really. For me, the inquiry is not over. I want the inquiry to take as much time as possible because I want them to get it absolutely right and hopefully make this the last inquiry in this field, if possible.
Because as we'll talk about, there have been a number, maybe not all public inquiries, but there have been a number of terrible deaths and a number of inquiries into those deaths. There were so many failings, it seems. It's very difficult to know where to start. You know, the police failings were interwoven with the failings of the mental health services. But start with police. Sanjoy, you've said that the police missed the greatest opportunity of all. What do you mean by that?
Well, you know, there was a streak of violence with Valdo Calacane that was missed from childhood that has not been investigated still. There are stories that have emerged but have not been formally taken on by the police. There were incidents of violence where a young lady escaping him from 2020 jumped out of a window, fractured her spine terribly. There was no police charge. So we had to, as a family, go in investigating these events. And it was really distressing because I remember a journalist telling me that, do you know, someone fractured their back trying to get away from him. And we had to then look into it and find out. And we were stunned because we thought, crikey. And I thought, you know, if someone's jumped out of a first floor window, the injuries would have been really significant. Surely he must have been charged with ABH or GBH or something. Finding out there was no charge. And we had to investigate this to get it started. So, and that was just really just the start of the police failures. And then he was violent on several incidents. To not have a running profile of this man is ludicrous on the national police systems. And then, of course, you know, the missed warrant, etc. There were so many episodes of violence.
And as I say, it was interwoven with the mental health services who were supposed to be looking after Valdo Calacane. Give me a sense of some of those failings.
Yeah, well, I think because there was a total and utter lack of communication and information sharing across all of the agencies. And we're talking about the university, we're talking about the Mental Health Trust, we're talking about the social workers, the mental health team, on the crisis team, and of course the police. And this pattern, it doesn't take a genius, it doesn't take somebody with any legal expertise or even any medical expertise. When you look at this catalogue, it was always going to happen. And he was sectioned 6 times in, was it less than 2 years, wasn't it? I think we worked out. And 6 times he had mental health assessments, but 4 times he was sectioned. And the first one he should have been sectioned. Well, probably all of them he should have been sectioned, but each and every one was for threatening and violent behaviour against others. It wasn't at risk to himself. It was at risk to strangers. It wasn't at risk to his own family. And when you piece it all together, and the inability for every single agency to be curious and to share information and to just do the basics of their job properly, has led to this catastrophe.
James?
Yeah, I think there's been missed opportunities from everybody, and I feel now that we've had everything laid out in front of us, there isn't a certain point that we can pin it on. There's so many things that could have and should have happened that would have pushed Calacane in completely different directions, albeit he got the treatment that he needed, or he was arrested and sentenced for his crimes, or just pushing him towards his family where he can get support from his family. So many things could have been done to stop what had happened.
Marjorie Wallace, you've been working in this arena for 40 years.
Yes.
Failure to assess risk, failure to act on risk, different agencies not talking to each other. Literally none of this will be new to you, will it?
Not at all. I've been to over 30 inquiries, not all public inquiries. I've supported the families, both of the victims and the perpetrators, who are often completely kept in the dark, not told anything because of confidentiality, and are given no help when they ask for it. And I find I'm so frustrated, it just beggars belief that if the mental health services and our services cannot cope with someone with that degree of violence, what does it say for the rest of the people, the hundreds of people who call us at SANE? I mean, what does it say for them? They tell us we don't reach the threshold even to get into a hospital, let alone be sectioned. If they cannot cope and actually discharge people when they're still so unwell. And we have now a policy of treating everybody in the community, getting into the community. How are we going to do that and keep a balance of rights between the patient, the families, and the public? And I've been saying this for such a long time. We go on the side of the patient far too much in many cases. We're all for patients' rights, but in these cases, we go on their side and we don't take the steps that we could to contain them and keep them in hospital until they're well enough.
I want to come on to that very specific point because I think it's really important in this case. But Norman Lamb, all the years that you were working in this area, Minister of State, any of this a surprise to you? The sort of litany of failings across and all those authorities who are meant to care for all of us?
Feels a bit shocking to say it, but I don't think it does come as too much of a surprise, I'm afraid. I think the risk of things going wrong is very real on a continuing basis, because I fundamentally think that the mental health system is quite broken, I'm afraid. We talk a lot about the principle and the value of early intervention, and how if you intervene early, you can stop a deterioration of someone's health. But the way the system operates, it intervenes very often at the latest possible moment when the crisis has already happened. So we've got it completely wrong. You often have very high thresholds to even be accepted onto a waiting list. And then you have to wait a long period of time. I mean, we've experienced it as a family ourselves. We were told when our son was very unwell as a teenager, we'd have to wait 6 months before anything happened. But we were desperate. Now, we paid because we could. Most people can't pay. And you're just left waiting, desperate for help. So I think the way in which the system operates, the plethora of teams, people get shunted from pillar to post, no one ever gets to know the individual, no relationships are built. I mean, however bad or difficult a relationship is with a particular person, we have a duty, a public duty, to try to build a relationship, to get to know them, to understand what in their past might have been the trigger for things starting to go wrong. And then you might stand a chance of helping that person recover. But all of that doesn't happen in too many cases in our system.
Dinesh, it has been 40 years since the equally awful and high-profile Christopher Clunies case. He killed Jonathan Zito. He was a paranoid schizophrenic. That was supposed to be a line in the sand. You would think 40 years on that we would know more, we would understand more, we would just be better. What has gone wrong?
I think there are a number of issues that we need to look at. I mean, firstly, mental health is seen in isolation. We don't see it as part of health. We don't see the impact other factors have. Mental health, to my mind, needs to be an integral part of health, which is affected by things like education, employment, justice system. And we've been hearing that police were not either sharing information or not taking it seriously enough. And I think we need to look at it in a much more joined up way than just, it really drives me crazy, and that's a DSM diagnosis, that, lessons will be learned.
Yeah.
Ugh. We've been here before.
Yeah, we banned that trite phrase because they haven't been learnt, have they?
No, they haven't.
No. And I think it's also partly that it's kind of seen in isolation. It's the mental health team's problem, and it is the doesn't meet our criteria kind of problem. Yeah. But it is also culture of the organization which we need to look at.
I agree with it, but culture is often bad.
I want to talk to you as families about the culture that you have seen played out in this inquiry. Within the agencies who were charged with looking after him,
Yeah.
protecting the public.
Yeah.
What have you found as you've heard the evidence?
Where they work in silos, there's very little curiosity beyond their tunnel vision quite often. Unfortunately, we've come up against quite a defensive, evasive approach. I would also say sometimes arrogant. There's particularly within the criminal justice system, as soon as we started asking questions as families, when we were presented with the horror that it was going to be manslaughter and diminished responsibility, that was the moment where everything started to really change, and particularly the way that we were talked to and dealt with. And as Sanjoy has already said, he knows what he's talking about, not just from a medical perspective, but I don't know how many years it was you worked in as an FME in police stations, but he's been there. He's literally got the badge and the award for that. So the at times disrespect, but the clear irritation that we weren't just complying.
That you were
that
still asking questions.
And we were still asking questions, and we were kept apart. I would go as far as say we were kept apart from the Coates family for, the entire time, really, until the sentencing, when you and I spoke to each other outside the courtroom, exchanged phone numbers, and we'd all tried to reach out throughout the summer of horror and the autumn and winter of horror, and we're told effectively they wished you well, but wanted to do their own thing. And I think it was managing us down. It was managing us quiet. So,
I mean, Sanjoy, you work in the NHS.
Yeah, I think there's a real culture of professional protectionism. And I think people, and I think it's a flawed protectionism. Protectionism is not a bad thing, but it's a flawed professional protectionism. And I kind of don't get it. And the reason I don't get it is that there are thousands of psychiatrists that get up and do a damn good job every day.
Yeah.
Loads of people go out and do a good job every day. People also who talk about funding in terms of culture, I don't like it one bit, because I know thousands of doctors who go out every day and do their job properly. It doesn't matter about the funding. We haven't had funding in the NHS. I've been in it. You guys have been in it a lot longer. I've been in it 30 years. We've never had the funding, but it hasn't stopped me going out and doing my job. And there are thousands of doctors who do that every day. But this culture of, I think, I'd also like to slightly not disagree with you, but say,
That's allowed.
I think, I don't think mental health is broken, because that's an easy cop-out to say that everything is broken. So what do we do, I don't think it's broken. I think it's in a state of disrepair. And I think what we really need to do is get this right. We have had professional lethargy in our case. And I think the thing about professional lethargy is really, it becomes endemic. And if you don't do something about it, and the only way that we can do something about it is by holding people accountable, because that is the way to change systems. I think for far too long, look, if you've got someone who's advising the Secretary of State for Health, telling them that if you start holding psychiatrists responsible, there'll be no psychiatrists. Now, I've never heard such utter nonsense in all my life. What about high-risk surgeons? Do we find our country's has no high-risk surgeons because they carry out high-risk surgery? It's utter nonsense. But you've got people like this advising people in power. And you can't have advisors like that all the way from the Royal College of Psychiatrists downwards. You just can't do it.
I don't think there's that much between us, actually. But what I have witnessed over the years is too many people describing to me how they feel they've been failed, or their loved ones have been failed by the system. Now that does come down to individuals. With a system is made up of individuals who all have an accountability and a responsibility to behave effectively. But I think the way the services have been designed in recent years, with a multiplicity of different teams. I think there's something like 11 different teams in a neighbourhood, and a lot of time is spent sort of deciding whether someone should be admitted to a particular team. Now, that's wasted time. We should be devoting our time within the system to supporting people to help people to be safe, to prevent these sort of awful crises from happening. But if you're shunted from pillar to post, from one team to another, no one ever gets to know you, you disappear from the system, you go off the radar. And the idea of being discharged because you've disappeared is so ridiculous.
That was so extraordinary
because
to me. Because that is the moment,
that's the alarm
surely,
bell.
when...
It's the alarm bell.
And if you ever need a team, it's now, and the team need to go looking, and they need to do something.
It's a proper psychiatric red flag moment.
Yeah.
And in fact, they used that red flag and they buried it. And you know, as you say, neighbourhood teams as well. Let's not forget, someone like Valdo Calacane would not go to a neighbourhood team that they're trying to establish now. He's in fact the sort of guy who'd shuffle between teams and try and disappear down the cracks. So when we were also given the answer that maybe neighbourhood teams and neighbourhood hubs is the way, I fear that it's going to miss people. And what I don't like, I'll be honest with you, is government spending good money, and apparently they're piloting 120 million into these centres. Yes, of course you've got a need. You put something out there, you put a shop out there, someone's going to buy something. But is it going to serve the community in the best way possible? I fear not.
Marjorie wants to come in briefly,
Yes.
Norman, and then Dinesh, if you
Yes,
do too, please.
well, our particular concern is the treatment of families of victims and families of perpetrators, because we've come across it time and time again, desperate people trying to get help for someone they know is potentially dangerous, that if they don't take the medication, as we know in 90% of the cases when people become acutely psychotic, and the way that they shun these families. Now, we in fact, were supporting the family of Valdo Calacane because they went to a lot of people and no one in the world would listen to them and what they had been through and the way that they had tried to get help. Now, you can't expect every family to know. They weren't told it was schizophrenia. Now, you can't expect each family to deal with something they know is a serious problem when they're not given information because of confidentiality, without doubt, and they're not given support. And these families are the ones that come to us all the time on both sides. I mean, if we could prevent, we believe, at least a third of the suicides as well as homicides, if people listen to the family. And one research we did, which is really interesting, we did a research on 100 homicides committed by a mentally ill or disordered person. And we found that, of course, 75% was lack of sharing of information, communication, risk assessment, but 52% were failure to listen to the families or relatives of people, and 30% were failure to listen to the patients themselves when they were needing help.
To do everything you can for your child, even if they are a grown adult, you do have to see them and be in touch with them. And I think with the Calacane family, there was very little contact, which we found now. The mother saw him twice was it 2 or 3 years? And was present when he was diagnosed. That being said, I'm not putting the blame at their door. Could they have done some things differently? Yes. But there can be an over-reliance on the family to become their carers or to identify things. What we have in Calacane's case is he's in that minority, thankfully, with seriously mentally unwell, where he's dangerous and violent to others. And that isn't normally the case. I do understand that, but there are 2 murders a week for mental health homicide, and Calacane would never find a neighbourhood team. Calacane manipulated the system and the clinicians and the police to let them, ridiculous as it seems from the evidence we've had, that he was taking his medication, that he was complying, that he was on the, have a telephone call to him to say, are you taking your meds? Yes, I'm taking my meds. We've been sectioned 3 times and they knew that he was non-concordant with medication. That's not the health teams checking robustly. That's when he had been seen taking meds out of his mouth, for example. So I think there are so many strands of this that when we've just sat through months of evidence, but Calacane was never going to be concordant, would never have complied. So how do you deal with those people, neighbourhood teams and community carers?
I go with you, Emma. I go with you 100% on
Yeah.
what happened with him. I think you can't. the families that we're in touch with, when they try to seek help, they simply don't get it. They're put in long waiting lists of, 18 months. They're often not believed. Now, in the case of Calacane, they didn't actually spot the signs, but that's not the point. The point is that at the point, there is nowhere to go if you're a family member and nothing has yet happened. And what we're hoping is that their families are encouraged to go and speak about the problems they have if they spot those sorts of problems in teenagers and afterwards. And what they feel is too afraid to go. And we need to make much more open doors for
Marjorie,
those families.
Marjorie, you have a general point, but we are here to talk about specifics of our case.
Yeah.
And may I just say, the specifics of our case is slightly, as you've said, are slightly different. And I'll tell you why they're different, because Calacane's mother was a nurse, and she was a highly qualified nurse, an ITU nurse. Calacane had 2 episodes where he drove home and sat in a car outside his house. 2 occasions where he was acutely psychotic, when he shouldn't have been driving, when he actually arrived and sat outside. Now, if any of us around here, we're all family people around this, around here, this panel. If one of our children drove home to Wales, 200 miles down, and sat in a car all night and then drove back the next day, and you knew he had some form of mental illness, psychosis, would you not ring 999 or an emergency service
Or
to
their
stop him
crisis team.
placing him or the public at risk? This happened twice. So I'm afraid family does have a very important part. And I think, what Emma, myself and James are certainly not going to do is have the wool pulled over our eyes about our case. Because we are here to talk about our case, not about general stuff.
That is understood, but of course we don't have Celeste Calacane here to defend
Absolutely
herself.
right. We keep glossing over the fact that there are 4 sectioning events like it's normal. It is not
In less than
normal
2
to
years.
section anyone. To deprive someone of their liberty even once is a horrendous thing to do for patients.
Yeah.
But to think that he had 6 mental health assessments, 2 of them were flawed when he should have been sectioned because he was sectioned immediately afterwards. But you're depriving patients of their liberty with such ease. And in the inquiry, what came out when we asked the question was that apparently they'd had several patients who were sectioned on multiple occasions. That in itself is a sign of failure.
You see this
ask,
repeated
Yeah.
relapse.
Yes.
And
But I think that goes back to the culture of the organization, culture of the place, practice that, it's okay to section somebody 6 times.
Yeah.
It is not okay.
It's completely wrong.
But is the debate in their minds? We have to give this patient autonomy. We have to give them some sort of agency. And the balance, as Lewis Appleby says, is not
Jackie,
correct.
Jackie, I would disagree. I would say these are people who don't know how to use the Mental Health Act. You don't if you need time with your patient, use Section 3 of the Mental Health Act. These people did not take time with their patients. And whilst you brought up Lewis Appleby, I'd like to say, so he's been commissioned, and his team in Manchester University has been commissioned to run the National Confidential Inquiry. When they were short of funds, they decided to drop homicide out of it. So yes, there was a 15% deficit they had to make up. And so they dropped homicide. To me, that's a disaster waiting to happen. How can you drop something so enormous? Now they've decided to bring homicide, but with limitations. So that means that a patient who's under services for a year will be included. And now they're thinking of broadening that to say anyone who's been in touch with mental illness, which is what it should have been in the first place. What we are also as families arguing about is that it shouldn't just be homicides. What about the actual bodily harms, the grievous bodily harms, and all the other harm caused by mental health? Who's measuring that? And as a government, if you don't have the right data, you don't know the size of the problem. And right now, I would challenge the government, the National Inquiry, and the Royal College to give me data on their patients. They have none, and that's a disgrace.
And they've started to sanitise any of these inquiries. Now, I couldn't agree with you more. I'm on no one side here. I'm on the side that I think families should always be listened to. It should be mandatory that people take down concerns about families, which it isn't everywhere, and that it should be part of the care team. I agree with you on all of those questions. What we're actually needing is far more family involvement
Absolutely.
in the in their situation, whatever stage they are, and training.
Absolutely.
And also the lack of stigma, and it's the fear of saying there's mental illness that
Families are
still
ultimate safety
stops
net.
everybody going for help.
There's a fascinating approach which was developed in Finland called open dialogue, which has now been trialled in, I think, 6 sites in the United Kingdom over several years. But the whole basis of it is that you work with the individual and their family or their wider circle of friends. You talk openly, you try to gain trust, because only by building trust will the person open up and you'll gain a greater insight into what might be wrong with them. I think from what I understand, the results are very exciting. Certainly the impact in Finland with people with psychosis has been very impressive. And I think we should all be focused. I think in a sense we owe it to all of you families that we've got to find ways of preventing awful things happening in the future.
And they are preventable, that's the thing.
This is absolutely right. And in your case, I mean,
and that's
you said
what's
right.
so heartbreaking.
You said right at the start, Emma, that there were so many cases of organisations not sharing information with each other. With virtually every scandal that we
It's every time,
dissect,
isn't it?
it's always it's the
every-
common factor every time. There's often fears about data protection when actually
and an excuse. Of using
it's
data
used
protection.
as an excuse where actually sharing necessary information is perfectly allowed
Absolutely
and
right.
absolutely necessary. Scandals
Absolutely.
don't happen because you share too much information.
But is
They
that a cultural thing about the obsession with Valdo Callicane's privacy, not releasing details about his mental health?
I think
seems from the evidence to have outweighed any obsession with public safety.
But I think,
think
sorry, go on, Dinesh.
I think it's always that when any inquiry you look at is the lack of communication. And there are all kinds of reasons given which don't make sense. Because it is, if you're concerned about somebody, then the group of people need to know, and if they're going to sort of take care of the individual, whether it is, general practitioner and community nurses or health visitor or whatever. And that again goes back to a broader cultural issue. Yeah. Every time I sit in a clinic in India, patients are coming with 4 other people, their neighbor and their mother and their friend, and and nobody bats an eyelid about it. Now,
And they're the people who know the person, aren't they?
Exactly,
Yeah.
and it's not to say that they feel stigmatized. They're coming to see a psychiatrist. So what is it that we need to do to shift that focus? Whether, it's simple education, perhaps more than that. Is it sharing that information, sharing that knowledge, sharing what's going on? And part of me thinks that people get very defensive.
Yeah, I
Absolutely.
agree.
The secrecy and stigma have a huge overlap.
Exactly.
And it's covered up by secrecy.
Yeah.
And if you make something secret, you're nearly making it a stigma to talk about that secret.
Yeah.
And that's completely wrong. Like, again, in our case, they should have talked to university about him. This was a 30-year-old man, as a mature student, living amongst kids who just turned 18. It was abhorrent that his risks weren't. When he assaulted a student, he reported it to a lecturer at university, apparently. But again, people didn't speak to each other.
Yeah.
A university lecturer said, well, maybe you should fight back harder the next time, or something really quite ridiculous like that. But you've also got mental health services. But you see, the thing is, for me, ultimately, the owners of that risk were the psychiatrists.
Yes.
It was
the
their
worst
duty
thing,
to
do you
share
mind me
that risk.
Just saying, the worst thing, I think, of all the phrases was saying that he didn't wish to engage with services. What I want never, ever to hear that said, that the reason for not doing anything is that the person didn't
Non-engagement.
wish to engage with
But
services.
what do you do in those
Well,
circumstances?
you go out and find them.
Yeah.
Tim Kendall, I don't know what you thought of his evidence, but he was the former National Clinical Director. He works with homeless people, and he talks to me. He says, I go out and find them, sometimes with the police, You find them on a park bench. You talk to them there. So this idea of refusing to engage, well, we go out and engage with them. And actually, sometimes if you're patient and you and respectful, you can find a way of opening up a conversation. And there was a wonderful example that Tim gave me of how someone who was seen as being someone just wasn't engaging, how he got a conversation going, understood what was happening, and then you can start acting as a clinician in a more effective way because you've understood what you're dealing with.
But the problem with Kendall's work is that it is assertive-like. It works on assertive principles, but it's not actual assertive outreach. I'm sure you'll agree with me that assertive outreach is a set of principles that cannot be overlapped with just assertive principles. It is a proper way to manage patients.
Explain what you mean for those who don't understand assertive outreach and how it works properly.
So Nuwan Desnyanka gave very good evidence at the inquiry.
Oh, he's an incredible
And this is
man.
not, and his main point was that you have services that try and do assertive outreach on either the cheap or they try and do an aspect of or a principle of. Assertive outreach is a set of grounded principles where you go, as you say, looking for the patient and assertively looking at their medication, assertively giving them their medication, and put assertive in front of every word that everything that you do for the patient. It is, has a different set of principles, but you can't replicate it like assertive like or assertive type. It has to be assertive.
Which is what many in the field say is
But I think one
Absolutely
of the key
right.
They're
issues...
leaving, sorry, can I just say, we get so many cases where people are supposed to be monitored every week or every few days.
Absolutely right.
And all they do is they leave a card
It's
on their
hopeless.
doorstep
We
saying
had it.
he
Absolutely right.
wasn't...
We've heard that here.
And we can't
He
have
wasn't
that if we're going
present.
to care in the community, are we?
No.
We can't carry on like that.
That's
if
where we
gonna
need to
care
make
in
the
community-
investment so that we have the resources to get to know people and to reach out to.
I think it's simple things like, what are people's models? Where do they go? And, my work in Southall years ago and looking at psychosis rates across different ethnic groups and things, Punjabi women who feel depressed, they'd rather go to the temple or the mosque or the Gurudwara. So why are we not providing services there?
Of course.
So that's kind of assertive outreach because people who use substances, we need to find out, because if they're going to a club or whatever, why don't we have somebody sitting there?
Yeah, rather than the hubs.
Yeah.
I don't think that's going to be quite assertive.
I'd love
but the
to
hubs.
take you there sometime and to talk to the people there because, there is the hub and a lot of people come into it, but you're absolutely right that you've got to go out from it. But having a team that has a responsibility for a geographical area and it's their responsibility, the mental health of that community, and going out to find people when they don't come to you, that for me, a single team, so you're not shunting people from pillar to post, that's the best way of getting to know people,
I'd
understanding
agree.
the problem.
As long as there is an assertive team
totally, I
based
agree.
at that hub.
And you have
The
to say-
assertive notion of it, though, has to, in the end, involve some sort of force, surely. If someone is continually
Well, if
in the
there's a complete
community,
refusal to engage.
that's a very difficult position to be in, isn't it? We knew that he refused the depot injection.
Yes,
And he
well,
was allowed
therefore,
to refuse
but the
it.
Mental Health Act wasn't applied properly because it should have been. He was never going to be concordant. I think with assertive outreach, it's very staff labour heavy, non-political labour, by the way.
It's expensive.
And it's expensive.
And you need two people.
But it's a small portion of people who require that level of care, and I'm going to use the word care because that's what it is, because they are never going to voluntarily come into to hubs. And I think that what we are seeing, especially with the new Mental Health Act, that these targets are sort of being added. That it's like a wish list of this is how we would like it to be. It's not how it actually is. And something like 20% of our medical need in this country is mental health related, yet 8% of the budget is afforded. And who said stigma? I'm not sure who said stigma, but stigma it's a word that's come up, particularly in the last few weeks, an awful lot. I don't know who's causing the stigma, but I don't think it's the people that need the care that are causing the stigma, or their families. Because you should feel no stigma.
Yeah.
If you need help, you need help.
Absolutely.
If you have a member of your family who's dangerous, they're dangerous. I think it's the hot potato that is mental health. I think the inability of our passive reactive state to recognise that we have to have difficult conversations that do sometimes talk about race, they talk about culture, they talk about background, and they talk about trauma. And we have to recognise and be preventative rather than reactive.
It's so good to hear you say that. Passive reactive state.
I do believe that's what we've become in this country.
Describes our approach, I'm afraid. And the idea of a greater focus on how we prevent things going wrong in the first place, including in childhood, where...
and it's an uncomfortable conversation to recognise, the particular... It came up in the very, very first week of the inquiry that Callaghan wasn't sectioned the first time because of his ethnicity, and there were too many black men being detained in Nottingham. I mean, that says it all. And that's appalling to anybody from any ethnicity. If you need help, you need help.
Dinesh, as a doctor, we know that black men are disproportionately sectioned, disproportionately likely to have serious mental health, and it's an extremely complicated issue. Is it ever acceptable for a physician to bear that in mind when they're making a decision?
No. I think you really have to look at the needs of the patient, protection of the patient, and protection of the public. So that needs to be balanced. Color should not come into it.
That's where the stigma's being created by sort of this idealistic target setting.
I think this is dangerous.
From well-meaning politicians, but not prepared to.
Stigma is surely made worse by people who are killed by someone with a mental health.
I think
Right.
the quickest way to get rid of the stigma is to treat the patients with the treatment they need. And when you start to see these people improving and getting a better life, that's when the stigma goes away. But stopping people from having treatment because of certain criteria is always going to leave that stigma over the top. I feel public safety should be number one, and there shouldn't be a budget put on public safety. And over the last 4 months, we've seen that public safety was not at the forefront. It was always bottom of the list. And that's why we're in this situation.
You talked about treatment by force. Let's not forget that Callaghan received 2 intramuscular injections by force when he was sectioned. And of course, they controlled him. So that's a real key thing.
Of course, and he was compliant because he had to be while he was sectioned. But then he came out and he wasn't compliant. And they disengaged from him precisely at the moment he needed most help. And
absolutely.
Public safety
and
was
he
at
was
risk.
responsive, and it was complete. This is where the wrong was absolutely wrong. They discharged him when they knew that he responded. If he'd been unable to respond, and there's lots, he responded, and they knew that, and they still discharged him, and that was where it went wrong.
Well, that's something where we had massive fallout in our case as well, because we had a psychiatrist who said in open court that he was treatment resistant. Now, following the NICE guidelines, he was not treatment resistant. No. He resisted treatment. And that's one of the big flaws in our case. And that is something that we are going to be looking at, and we are going to be chasing the tail off, basically. But, I'm afraid the way the Mental Health Act is at the moment as well, in its current form, yes, it hasn't been deployed yet, but the point is that I think we have gone too way off to the left, given way too many rights there, and we are actually shunning safety of the community.
And can I give this back, the fact that they are not giving more rights to families?
Yeah,
absolutely.
They're
right.
given no rights of knowledge. They're given,
Community.
it's just completely random as to whether they're told what's happening. Actually in Callaghan's case, they were told he was fine. I mean, I'm not defending either side, but they call on people instead of visiting them. A lot of the monitoring is calling. Now, we go back to the fundamentals that we believe is that there's very little people can do with somebody who is needing long-term help and relapses. And we have lost half the number of psychiatric beds since 2000. We only have 18,000 psychiatric beds. We have lost the number of doctors and skilled or experienced community nurses. The government has said that they're going to give us 8,500 more workers, but that is just replacing the workers that have burned out, have left, have been moved around. So all those pledges aren't any good. We have no crisis beds. I think that every single trust should have a crisis unit where people like Valdo are kept for for a week or two or more, if necessary, while they're being assessed. So they're not snapshot assessments. That's the sort of thing I think we're needing. We're needing to actually think again that it's like physical illness. You need to have the fundamentals of a hospital or a place or a safe place for someone to be, as well as the community. You can't treat everyone, however ill they are, in the community.
Can I just push back slightly on this question of coercion? And it's really important to say at the start of this that we're all trying to achieve the same thing. But there is a risk that if coercion becomes the dominant approach, I accept that it has to be there in reserve for when things don't go right and when you get refusal to engage. Absolutely. But there are unintended consequences of an overly coercive approach. And I've come across many cases of people who avoid services because they know that if they go in, they're going to get locked up. So that you create almost an incentive for them to disappear. I had one guy who actually disappeared abroad just to avoid being in mental health services. And when he came back and wanted to re-engage, he said to me, I didn't open up with the doctor because I knew if I told the doctor my full situation, they would just lock me up again. Now, we've got to find ways of getting people to open up, have the conversation so that we understand them and then we can support them in a more effective way.
And the question always has to be, given what's happened, how you manage the risk, isn't it? And that, presumably for you as families, it wasn't managed in this case. So you're less concerned about the worry of coercing people or not?
I don't like the word coercion either.
I don't like it at all. I don't think we are fans of the word.
I know it's used,
coercion.
but it sounds like a very harsh word. You know, it's assertive. Another one. It's difficult. It's I think it's just giving the appropriate care that people need and recognising what people, patients, and their families need. And
we call it safe care and treatment.
Absolutely, safe practice.
Safe care and treatment,
but there isn't,
not coercion.
That's when you'll get rid of the stigma.
I think coercion is a word. There are certain words in psychiatry that I would like to see disappear. One of them is coercion, and the other one is capacity, because people get totally confused. And I can see you smiling, but I tell you what, I'd like capacity just changed with the word understanding. Do you have understanding? Let's make it simple. Do you have understanding? If we just had the word understanding instead of capacity, we get a lot further than capacity. Because, that's a word that's used really badly by people in situations where it doesn't deserve to be used. And coercion, unfortunately, has negative connotations.
Yes.
If that means persuasion for the right treatment, then what's wrong with that? But coercion is just a word that you use in other circumstances, but I think in psychiatry it's unhelpful.
But the reality also, which we need to recognise, is that when you are detained under the Mental Health Act, you're often placed in pretty dismal places. Not all, but a lot of inpatient wards are pretty awful. There's not nearly enough proactive work done with the individual. You go into some of these units and people are wandering around. There's no proactive work being done, psychological work being done with people. And then they're discharged a few weeks later. They may be in no better position than they were when they were admitted.
Isn't it?
And then there's a relapse, and the cycle just continues.
We heard that with
but I agree with
Calacaine.
that. But you can't put people in society because of that reason.
But I'm not arguing for a return of the asylums, but in the days of the asylums,
Well, that's another word we should never use.
There was outside space, there was gardening, there were things, there were meaningful activity that people got engaged with. Now you're locked up in a confined space with 18 other people, very little access to the outside world. Does that help you recover?
Isn't, in simple terms, though, I accept what you say about the word coercion. I'm going to blame Norman for it because he said it.
I wasn't the first to use it, to be fair.
But isn't the reality that you may want to persuade and have good services in the community and hope you can bring someone like Valdo Calacane in for treatment? If you can't, it is about making sure they are permanently detained?
Jackie, I'm not being argumentative at all.
Nor am I.
Can I just say, look,
You'd never be argumentative, Sanjoy.
I have to persuade my patients to take their diabetes medicine. I have to persuade my patients to take their hypertension medication. Am I being coercive?
No, but I'm asking what you would do in the case of someone like Calacane who didn't even believe he was unwell for a good deal of time.
You see, as a physician, it's my duty to point out the benefits. Now, that comes with everything that you've said, that you need psychotherapy, you need CBT, you need all kinds of positive things for the patient. And by the way, asylums, I'm not anti-asylums. Asylums, patients used to ask for asylum because in the day when they were built, they were fantastic institutions.
Well, I'm saying in many ways,
I think
sports and everything.
Exactly.
Again, that's stigma
sometimes you need
that.
asylum. You need to get away from
Sometimes
everything
people
else.
want
you
to
need
get
to be
away from the
safe.
world.
peace and tranquility.
You can't
Absolutely right.
You can't believe the number of calls we get of people who are saying we need to be somewhere safe.
Yes.
We're not safe
Absolutely
with
right.
ourselves.
I'm not feeling
And
safe.
they go
Absolutely
to A&E and then they are turned back
Which are
because
even
they
more
don't
unsafe.
reach the
The threshold.
threshold.
That's very true.
And they're left and they're told the community team will come round. They wait for 2 or 3 days on end. The community team doesn't come because they're overburdened. They've got double the number of people on the risk assessment, on the risk teams, on the crisis teams, and on the intervention teams. They've literally got sort of 24 to 1 person at the moment. And now, so there's nowhere, so the people ring us, left completely alone, but far worse and far worse state because no one's helped them, even when they begged to go in and get safe
community
care.
treatment order would solve the problem of the coercive approach to his treatment, because if it continued, then sectioned at the right level, appropriate use of the Mental Health Act and its powers, he would have had a community treatment order to have that depot medication that he did respond to when it was forced upon him.
But he had to be on the right section, right?
You've got to get the section right.
You've got to get the section right.
I
which was
can't
got
understand
wrong.
how can you be sectioned 4 times in less than 2 years? And he's kept him for a couple of weeks. We had one example, I don't know if you saw, where he was allowed a day's unescorted leave, which he took, came back in with a hammer. There was such little professional curiosity about the hammer. It was taken away from him. But when he left, a few days later, given back to him because they thought he might be hanging pictures. It's the level of care that we did hear evidence of. And he was just disengaged from any form of therapy. There was no assertive approach to try and get him to engage. He was allowed to have his laptop and his phone. We now know the kind of horror that he had downloaded onto his phone and his laptop, what he had been looking at. That's a whole other conversation.
Yeah.
But there does need to be a recognition that there are some people like Calacane who are extremely dangerous, are always going to be different in their management than the vast majority.
But also...
should be permanently detained.
Well, I'm not saying you should be permanently detained. I think it just that level of community treatment order and enforced medication, and that labour-intensive approach to caring for somebody like him.
But it doesn't really exist now, does it? In the assertive teams,
it's the
they've
minority.
disappeared.
It's not the majority.
It doesn't.
Care, haven't they?
It doesn't exist, and it certainly doesn't exist 24/7, which is what ultimately you should be thinking about. But I was going to say. Trieste in northern Italy is a place where they do mental health very differently. I think it's a very attractive approach, and it's all based around a neighbourhood centre which is responsible for that locality. But I think there's a really interesting perspective that they offered me when I visited there, that because someone's got mental ill health doesn't mean they're responsible under the law. They're not responsible under the law. So the criminal law, if someone
still
commits an
applied.
offence, it still applies.
Well, it's actually, if you look at our CPS policies, it's in there. They just don't do it.
So you made the point earlier about the failure to arrest and to charge when there was a clear, serious assault.
Criminal act. Yeah.
And that's a really serious. And I think if we want to respect people as full citizens, which we should do, with freedom goes responsibility. And that the responsibility, I think, is too often missed.
Dinesh, you were smiling at what Norman was saying. I don't get from agreement.
I mean, I think Trieste model is fine for Trieste.
No.
Exactly.
And it is kind of, what we need to be looking at is culturally relativist ways of providing services which suit the circumstances here.
But I think there are principles about how people are treated, which is...
But that goes back to the neighborhood hubs and so on and so forth. And do they work? Social prescribing does work. It's to a degree, we know that. But does it work everywhere?
But Dinesh, as an accomplished worker in mental health, the one thing I want to challenge you about is why has the Royal College, of which you have been the head of also in the past, why has it, to a certain extent, bracketed and pigeonholed this whole debate about culture and mental health? There have certainly been workers all the way across England who have been shunned by the Royal College for highlighting this as a problem.
I don't think so. I disagree, because the first report that the college did was in 1987 or something like that. And I've been involved in the college in various roles. And the first transcultural psychiatry special interest group was set up by the college in 1999. And I think part of the challenge really is that sometimes it is seen as your problem. You deal with it. And the broader community doesn't, if you see what I mean. But it is everybody's business. And I always use the example that London is a collection of villages.
Absolutely.
Each village has its own culture. And how do we understand what's going on in Hampstead compared to what's going on in Brixton?
But Dinesh, that hasn't been absorbed by the college at a granular level, because we are still talking about those issues. If the issues that you have just said were accepted by the Royal College, then
Well,
they would
I mean,
not be issues that we would talk about again and again. But
I'm
the
not
problem
part
is
of the
that that's
college,
actually-
so I don't know what's going on
I'm
at
not
the
saying
moment.
that you
And
are.
I'm not here on
not-
behalf.
I'm just talking to you as an accomplished physician. All I'm trying to say is that we're coming back to the same debates again and again because they haven't been absorbed at a granular level.
No,
But what do you mean by that exactly? In terms
I think
of... Sorry.
go on.
What I mean by that is that at the first sectioning event, if the doctors are finding an excuse to not section someone
Yes.
because it's on a ethnicity basis.
But he was then sectioned 4 times after that, wasn't he?
Yeah, but I mean, that was after the failure of the first one. But that was an excuse used when they didn't section him under the mental health assessment of the first, because there were too many black people who had been sectioned. Now, if that's applicable by a consultant in Nottingham, all I'm trying to say is that that's being used as an excuse.
But it's also not the predominant thread running through the failures here, is it? It's
No, it's
definitely
not
it's an
predominant, but
argument
it's-
to be
There are
discussed.
so many failures. We don't
But
really
it
have a
is a
predominant
No,
because there are so
I
many.
mean, there are main
It's
reasons.
an observation which, obviously needs to be teased out as
Absolutely.
to why it's happening. And there are loads of factors that, I've looked at in both my research and clinical practice, and it does raise some very serious questions. And it goes back to that you see mental health in isolation, in a silo, as you were saying. And we need to be looking at employment, housing, social support, judiciary, and it becomes easy to blame the color because it's obvious. We know that there's plenty of evidence that the rates of schizophrenia are not as high in first-generation migrants, but much higher in third and fourth generation. Why? We need
But Dinesh,
that's
absolutely everything you have
research.
said relates to diabetes.
Yes. But I'd like
Absolutely
to come
everything that
in
you've
there.
said. Why
and
hasn't
that's why I kind
diabetes
of
got the
really
right
liked your
management stigma?
analogy.
Yes. But research is one of the things that we campaign about. There just isn't the research being done into what to do with people like Valdo. There's not enough research into the how to treat schizophrenia. NICE is always turning down new medications or any innovative treatments. What we're needing is to take it seriously as serious mental illness and have the research.
See, what
that
we're
goes
saying is,
into it.
I think we have the research.
Well, we
I think
have
it's just
some.
not being deployed.
Dinesh, just about the issue of race, because it has gathered pace over the last couple of days. The research shows that there's disproportionate levels of serious mental illness among black men, but the research does not show that they're more likely to hurt anyone, or does it?
No, but I think the point that you were making, there's data from Nottingham. One of the first studies was, and Nottingham was one of the centres, Nottingham, Bristol,
yeah.
and London, showing that the rates are high. So why is that not being used in changing policy, in changing education, in changing services?
And it should be. That's why we're being reactive and not proactive in preventing stuff.
We're all
And there's a
here doing
fear.
wanting the same thing.
Yeah.
And that's what's so, I mean, after 40 years of working in this field, everybody is wanting the same result. Everybody's looking for the same kind of answers.
Yeah.
And every time we go to Secretaries of State for Health, they all promise everything and then nothing on the front line happens. And I think the only way forward is to look at the underlying thing, which is there are no places for people.
Very quickly, Norman and Dinesh, you know, if this is to be a line in the sand, and everybody truly hopes it is, what right now needs to be done to start the change?
Well, I think that these trials of a new approach to mental health, where you have a single team responsible for a locality, is something that's really interesting and worth persisting with. I think the learning from open dialogue, where you involve the wider family and you have an open conversation which gets to the bottom of what might be the cause of the descent into crisis. These evidence-based approaches can teach us a lot about both a more humane way of dealing with people, but also critically a more effective way.
Dinesh?
Clinicians need to learn how to deal with variety. They need to be much more sensitive, both public safety and individual well-being, and they need to bring it together. Policy needs to change to let that happen, because we reached a stage where you spend more time filling in forms than seeing patients.
Yes, very true.
And thirdly, I think research needs to be funded in teasing out the causations and looking at it in a culturally relativist way.
I know it's a lot to ask, because there are many changes that are needed, but for the three of you individually, what do you hope will change?
I think family needs to be involved in any disease,
absolutely.
not just mental health.
Absolutely.
If you have your family support, it's been shown that every disease outcome's better.
Yeah.
What I would like is accountability, because you have been someone who has worked in this field and given up your time for 40 years. It's ridiculous that someone's had to campaign for so long and see such little change in my eyes. Yeah. The point is, if you don't hold people to account, we will not get system change.
Absolutely.
And I believe the time has come to hold people to account, to change the system, because that is what's going to do it.
Yeah, I just have to mirror what Sanjoy said. It all comes down to accountability. 30, 40 years ago, this same thing was being discussed, and because no one was held accountable, changes were never made, and we're back to square one. So until people are made accountable, there will be no change.
Emma?
Yeah, you can't rely on having a statutory public inquiry to just get the truth and candour. What I do think has to happen now from a political perspective is it has to be addressed properly cross-party, because as you've seen, if you've all watched the news recently, it's the agenda. Our agenda is being picked up by people whose agenda is to do hate and to do harm and to politicise themselves and their parties, and that can't be what we need. What we have to do is recognise the facts, however unpalatable they might be, hold people to account, address those uncomfortable truths, but it needs to be done now, and it mustn't be a talk shop, which is what we've seen. So that's why we've said we need to see the Prime Minister, the Health Secretary, the Attorney General, the Home Secretary, who's the other one? Justice Minister, because all of them all of them have departments and agencies that have failed so grossly and grievously in our case. And they have to start now, and they have to be brave and get ahead of it, because if they don't get ahead of it,
Proactive,
we're
yeah.
going to get more and more and more of these terrible tragedies happening.
And finally, we approach the anniversary, and you are doing this work at the same time as grieving.
Yeah.
I just wonder what your thoughts are about Tracy,
At a
about
personal
Ian,
level,
about Barnaby.
I have time has stood still from when I lost my beautiful and brave daughter. I think I haven't moved on. It's been very tough to move on. But what's helped me as an individual really has been the fight and the struggle to change. To change, to make our country safer is now the ultimate passion. I cannot possibly, not just as a doctor, but cannot let anyone in our country go through the heartbreak that myself and my wife and my son have. I think it's enormously unfair, and we cannot have this again. This just cannot happen again. This should be the last inquiry. Whatever the findings are, we must put them in statute, and we must make laws about them so people follow them. This cannot happen again.
I feel, that there has to be changes made, because other people just can't go through this. Like, I feel that I've seen and heard things that no one could ever imagine, and I've pushed myself, I've pushed trauma to the back of my mind and tried to move on. But there's other people out there that might not have this, like, mentally be as strong or be able to stomach it. And I'd hate to wake up and see that it's happened to somebody else, and we just keep going on the way we're going. So I think, like, when it comes down to the anniversary and remembering, it's all about family and, like, looking out for each other.
Yeah.
But the fight still goes on.
Emma?
Yeah, carry Barney, lock of his hairs in here. He's with me all the time. But the pain of losing him is there are no words to describe it. It is limitless, enduring pain, and the fury that I feel that it was so preventable. So we've inevitably had to become the campaigners we are to get where we are. And I don't want us to be another inquiry where 10, 20, 30 years on, we're still talking about the same things. But the facade that you see from all of us is the strength that we use to do this fight. But the reality is the shell of what's left, and the catastrophe of losing him is, we'll never get over it, obviously. It'll be the rest of our lives learning to manage it.
Live with it.
The change is vital.
Yeah, we must make it happen. I want Barney to know that I and his dad did everything that we could for him, but also importantly for Charlie, to see that Mum and Dad did the right thing by his brother that was taken.
Well, look, I can't thank you enough for coming in, all of you.
Thanks for
so
having me.
much more we could talk about, but thank you so much, all of you. Thank you.
Thank you. It's been
Thank you
good
for
to
having
talk to
us.
everybody.
Yeah, thank you.
Thank you so much for coming in. I mean, we could have gone on for ages. Thank you so much. I appreciate it. And that is it from this episode of The Fourcast. Until next time, goodbye.